Okay, let's start with Apert syndrome. So, anomalies seen in Apert syndrome patients are head anomalies, face anomalies, and hand anomalies and foot anomalies. So, coming to the head anomalies, that is, we know that patients are having craniosynostosis and hand anomaly, that is syntactily. So, that will combinedly called as acrocephalosyntactily. So, that is another name for Apert syndrome. So, this patient is having tall peaked skull. So, like this, and fused digits, that is syntactally. So this Apert syndrome patients is otherwise called as acrocephalosyntactily patients. So coming to the clinical features of this Apert syndrome, so craniosynostosis, that is due to fusion of one or more sutures prematurely. It is a birth defect, that is one or more skull suture prematurely. Shape of the skull is dearranged because of premature skull suture line fusion. So that's patient is developed tall and short abnormal skull and mid-face abnormality. So that is uh, known as Tori brachycephaly. Curie means it is tall tower like, and brachy means short in front to back dimension. That is, the front to back dimension is short, and cephaly means head shape. So this patient is also having this shape, that Curie brachycephaly. So this patient, this picture clearly shows that tall skull and the front to back is short and the head shape is rearranged. So this patient is called as Curie brachycephaly. And coming to the facial abnormality, we have mid-face hypoplasia, hypertelorism, proptosis, and peaked nose. So this patient is having, see now, you clearly see the picture. So this is the mid-face hypoplasia and hypertelorism. Distance between interpupillary distance is more, and proptosis due to small skull and eyeball is protruding out, and peaked nose because of the mid-face retrusion, that nose is peaked. So these are all the abnormalities we know in the face. And oral cavity, we have narrow jaw and cleft palate. Too many are not enough teeth, and secondary complications because of the suture line fuses, elevated intracranial pressure, and damage to cornea because of proptosis and strabismus, and breathing problems that leads to sleep apnea. And coming to the hand anomalies, we have fusion of digits of the hand and feet. That syntactically is more specific to the Apert syndrome. That craniosynostosis with syntactically, that syndrome is called as Apert syndrome. That syntactically, that hand feet syntactically is specific to the Apert syndrome. Coming to the molecular mechanism, because of that fibroblast growth factor receptor 2 protein mutation, that is gain of function missense mutation of fibroblast growth factor 2 protein in the extracellular domain of the cell membrane. It is situated in the chromosome 10. It causes that gain of function missense mutation causes the protein signaling is excessively dysregulated, that forms early ossification. That's why that premature ossification of the skull is there, producing craniosynostosis and failed apoptosis. So that will leads to syntactically in the hands. So that is the mechanism which the molecular mechanism which the fibroblast growth factor 2 protein missense mutation will produce the Apert syndrome. Coming to the diagnosis, we prenatally diagnose this condition with anomalies and it is USG. And for cranial stenosis features, we will take MRI or CT. Better is MRI for children, but children are non-cooperative for MRI long-term hours. We will go for CT and we will know the status of the bone. And for confirmation, we will go for genetic testing of the Apert syndrome missense mutation in chromosome 10 with fibroblast growth factor 2 protein rearrangement. Differential diagnosis, I already told that type 1, type 2, that Cruzen's and Chatrizotan and Beaver syndrome. So coming to the treatment, because this patient is having lot of problems, treatment is more complicated. So this patient is having no cure. So surgical intervention only cure these problems. So surgical intervention also is done in early life. Before 1 to 2 years, the surgical intervention is needed to allow brain to grow and minimize the proptosis and improve cosmetic appearance of the face. We have to intervene early. So these children undergoes so many procedures. So important procedure is posterior cranial wall distraction. We will cut in the coronal plane and we will distraction is done posteriorly to lengthen the skull and fronto-orbital advancement. So we will cut in the orbit and frontal region over the head and we will distraction osteogenesis. We will distract the bone anteriorly and that will form the cranial wall growth. And for mid-first retrusion, we have do Lee-Ford 3 osteotomy. So that is done for mid-phase retrusion. So that will correct the facial abnormalities. And syndactyly release, we will do syndactyly release for hand fit syndactyly release. So this is the treatment we will done for this patient. So Apert syndrome is very complicated and the reniostenosis and syndactyly we will treat according to our protocols that will heal the disease. Thank you.